everyone. Welcome to another episode of the Control Yourself podcast. I am here with a familiar face, Dr. John Saratsiotis, who's been on the podcast before. John, how's it going?
All right, Rick. Good, man. How are you?
I'm good. I'm good. You're out in Athens. How's Athens right now? Probably hot as hell, right?
Good. Yeah, we're in the middle of summer, so it's fairly hot.
Wonderful. Yeah, I remember when I was there last year at this time, it was sweltering.
Yeah,
You have news on the Athens front that we just confirmed. We're doing FRC
hmm,
in Athens for the first time. I can see on our board. That's true?
that's that's right. Beginning of October, so October 4th and 5th.
October 4th
We're
and
hosting
5th.
an FRC. We've done a few FRs in Greece, so this is going to be our first FRC in Athens. So
There you
should be
go.
fun.
People can go and enjoy some of that beautiful climate. So anyway, today we wanted to talk again. Actually, not again. Last time we kind of touched on the topic, but we wanted to talk about palpation,
It,
and
it's
kind of,
it's it's funny how kind of doing things a little bit not backward, but we did treatment last time, so we talked about scar tissue.
that's right. That's right.
And now we're going back and we're talking about assessing using palpation. So we're doing the kind of the opposite.
The
So we're
opposite.
doing palpation second.
So I forgot about I forgot which episode it was, but I might put it in the link there. So
Hmm.
maybe we can start there and we can go back to that scar tissue podcast, and maybe you can give me a general sense of what we had concluded and what we had discussed, which kind of sets us up for, as you said, looking today at the palpatory or specifically at manual palpation and then how that affects therapeutic outcomes. So, if you had to encapsulate what we discussed before, what would it be?
So the big thing that we talked about last time was the fact that when we're treating, you're really not treating, you're not changing things as far as breaking up adhesions and breaking up scar tissue. We've never talked about stuff like that in the past. Pretty much what we're doing is we're kind of initiating a process with manual therapy. So we're using, directed inputs to create the process of change. And this is not going to happen just by using our fingers. We know that. We know that it takes a lot more force to change connective tissue, including fascia. But we also talked about the fact that using our manual inputs, and we kind of referred back to Langevin and some of the work that she did, and how using small forces, using acupuncture needles, you're able to activate fibroblasts, which are the basic, cells that create these changes in this tissue. So we're using manual inputs to kind of initiate changes, create an activation of some of the cellular components of that tissue, and then we're using on top of that more global forces, using stuff like some of the FRC concepts that we use in the system.
Okay, so then just to review, so what we were saying and what we have said, of course, I think the argument that we're breaking up scar tissue, breaking up adhesions, we've discussed this at length before. Although that's a popular straw man kind of concept that people might utilize to maybe denounce the usefulness of soft tissue therapy. As we've said before, that's never been our concern. We've never believed that to be what we were trying to do, nor what was actually being done from a physiological standpoint. So from a physiological standpoint, at least the way that we understand it, the way that we teach it, the way that we interpret the literature, is that mechanotransduction, or the propagation of force-based information or input over longer periods of time, lead to change in tissue structure, organization, architecture. Whereby, as we often discuss, we don't feel that the soft tissue application itself, or in and of itself, is enough to create long-lasting change. Just looking at the first principles literature on connective tissue, it's very easy, or one can come to the conclusion very quickly, that connective tissue, versus a lot of the other tissues in the body, is slowly adapting. It takes time under tension. It takes repetition of input, etc. So what we were discussing was the idea that the soft tissue application is maybe creating a window of opportunity by inputting direction-specific tension information into the system, which then we posit needs to be backed up by further information or directional information that we how do we say this? That we input utilizing specific contraction techniques, isometric techniques, stretching in combination with isometric techniques over time. So that it's, the idea of changing connective tissue architecture is a process of loading whereby some of the loading can come from a therapist's fingers in order to increase the specificity of the directional loads, but then it has to be backed up with exercise. And I think that's, in a nutshell, what we've been saying. We went a lot more specific in that last one. Did you have anything to add to that? I don't want to be too general, but at the same time, I just want to kind of overview what was said.
Yeah, I think that kind of covers it. The big thing that I think also is important is, we talked about outcome measures as well, and using outcome measures to figure out what kind of inputs you're going to place onto these tissues in order to create these changes. Now, kind of tying this in with palpation and assessment.
Actually, you know what, John, before I do want to tie one more thing up that we did talk about in that last podcast. And it seems silly to talk about it in retrospect now because the podcast clearly outlined where this term is effective and is found in literature, and that was the concept of fibrosis. So oops, sorry for that. Let's start off with that concept first. A review of what we said there. If I recall correctly, we were discussing the fact that fibrosis is not an imaginary thing, although it's been extended to include the concept of adhesion and scar tissue. We described how those kind of words or those words are not effective in this regard because it paints a different picture mentally of what you're actually feeling or looking for. We talked about fibrosis as being directional changes in connective tissue structure and how those directional changes affect the force parameters within the tissue itself, how it accepts strain energy, etc., how it produces forces, etc. So maybe just give me like a, the Cole's notes on fibrosis, because of course we are speaking in these podcasts to some manual therapists or people in our community who have questioned the usefulness of soft tissue therapy in general. Not only palpation technique, which we'll get to, but also just the existence of findings that we should be aiming therapeutic interventions at. So maybe you can just give me a Cole's note on that.
Yes. So fibrosis is pretty much like the natural repair that occurs within the white stuff, within the connective tissue. And so what happens is that there's an injury and there's an inflammatory process, and then the repair process begins. You get an infiltration of fibroblasts into a specific area where the injury is. And what's going to happen is that those fibroblasts are going to lay down collagen. They lay down usually weaker collagen with weaker bonds between the collagen fibers in a fairly disorganized manner. So what happens is that as this tissue repairs, the alignment of these fibers isn't always in a way that favors that tissue. And so fibrosis is pretty much the natural then healing process that occurs, but it occurs sometimes in a disorganized manner. Where we need to then place forces onto that tissue in order to create further change.
Now, for the manual therapists in the audience, this is not only a term solely utilized by manual therapists, as as oftentimes people are led to believe, but this is a term which is found over and over in surgical literature, in over a variety of different professions, correct?
Sure, it's everywhere. I mean, the real histological process is really, following an injury, you're going to get some adhesions into that area. Those adhesions then mature into fibrotic tissue.
Again, not the adhesions that we're talking about that we can palpate. This is from
exactly.
a microscopic level. Okay.
Right, and we'll get into this, within this podcast. But yeah, these aren't adhesions that we can palpate. We're talking about like microscopic, at a microscopic level. So, think about collagen fibers of 300 nanometers in length. So it's fairly small. So not only can you not palpate it, you can't even see it. You need a microscope to view it. So, you get adhesions kind of blending into like fibrotic tissue, which then matures in a more pathological, I guess, state, it becomes scar tissue.
Okay.
Okay, so yeah, fibrosis is part of that process, and so what happens is within the connective tissue, you get a disorganized deposition of collagen fibers that are very weak, and tissue that it is very weak, stuff that you can see, whether it's under a microscope or even through imaging. So let's say you get a tendinitis that becomes a tendinopathy, in chronic Achilles tendinopathies or like a supraspinatus tendinopathy, you'll see fibrotic tissue within that tendon.
And that becomes visible from a surgical standpoint as well.
Of course, actually,
Yeah,
there was a
I mean,
study.
I know you know this, and I know this. We've been present in a variety of different surgeries, but again, I'm trying to remind the manual therapists in the audience, maybe the manual therapy students, because as we said before, um, there is somewhat of a, I don't want to call it a backlash, but a resistance as of late as to not only the effectiveness of soft tissue therapy itself, but as we're going to get into the effectiveness of our outcome measures leading to the desire to apply soft tissue therapy. So again, fibrosis is real. I think just on the outset, we're not saying that movement itself does not often lead to reorganization of said connective tissue, but we are saying that repeated strains, repeated loads that with insufficient time for healing to occur, chronic tissue strain, even acute tissue strain, oftentimes the healing process, at the end of the healing process, you are left with, with tissue that is more optimal than it was, when the injury occurred, but less
Right.
optimal than it was prior to any of this occurring, meaning that, as I often say, all injuries come with anatomical consequences, and it isn't the job of the body to repair those anatomical consequences back to the way it was before. Rather, the evolutionary process is such that we evolve to mend the problem as best as we can in order to immediately restore function, which,
Right.
as we know, might immediately restore function, but cumulatively over time, when you start to accumulate more and more of this fibrotic development, very quickly things that weren't dysfunctional can become dysfunctional very rapidly.
Right. And this is why sometimes we get re-injuries into areas that already have been injured. So,
Very good
um,
example. As we often say, the first injury you're going to sustain after rolling, inversion, a sprain of your ankle is going to be an inversion sprain of the exact same ankle. So again,
correct.
there's lasting findings. Now, maybe this is how we tie in as you were trying to do earlier. So let's tie this in now to the outcome measure that is palpation.
Right.
And now we're talking um, about our ability, so to speak, to identify these aberrant tissues, but maybe we should step back first in terms of palpation and maybe define it in the way that we do when we teach it, whereby there's two main conceptual frameworks in which we palpate. One being the framework of identification, which is, of course, our ability to isolate anatomical structure. And then
Mhm.
two being the interpretation, whereby we can take sensory perception when palpating anatomical structure and translate it into um, clinical decision making regarding diagnosis, regarding what's going on in the tissue itself, and how do we then apply forces. So there's identification,
Right.
interpretation. So maybe we can start with one and then move to the other.
Right. But I think identification should come first. I mean, I guess the way we should look at it is that when you look when you look at a human system, right, and you look at things that we engage in with as manual therapists, there's a couple of tissues that we're really looking at. So there's a couple of target tissues that we really want to assess or that we assess as manual therapists. So there's muscular tissue, so there's the red stuff, so muscular tissue, and then there's tissue that we call connective tissue. And so both of these tissues have to kind of work together to generate whatever they need to generate from a movement perspective. Uh, Specifically, what we want to do is we want to tease these two things apart because they kind of work in conjunction. And in order to better understand what each tissue does on its own, we need to be able to tease these things two out. So I'm not saying that we're able to palpate or differentiate connective tissue from muscular tissue, but part of our assessment using palpation is being able to create stress conditions onto these tissues. And we do this using length in order to be able to differentiate between an outcome measure for white stuff or connective tissue and red stuff, which is muscular tissue. So, so we're using palpation to do this. And, I might even, when it comes to identification, I would even take it a step further back. And I would go back to touch as far as palpation goes and what we know about touch, because I think that's where we should start is how is touch represented in our cortex. So what the cortical representation of touch is in our sensory cortex. And if you take a look at touch and the representation of touch in our cortex, for our hands, it's probably 100 times more than it is for, let's say, our back. For those of the people that are listening to us and watching us, if you go back to our neurology and we think about the sensory homunculus, which was that little short guy with the big hands and the big feet, there was a reason why it was depicted in this way. It's because in our sensory cortex, those parts of our body, so our lips, our hands, our feet, have a lot of receptors. And so we need to understand that, and we need to understand that these areas of our body have a lot more receptors than other parts of the body. So that's going to give us an advantage as far as being able to train this as a skill in order to improve it and be able to use it when it comes to palpation.
Like you're saying from that standpoint, in our fingertips themselves, there's a diverse number of receptors. Mesenter's corpuscles, Pacinian corpuscles, Ruffini's corpuscles, the free nerve endings. There's a variety of these receptors, and
not only is there's a variety, but there's also a difference in density. For example, even within our hand, within the palm, there's about close to 60, I think 58 to 60 units per centimeter squared of receptors versus our fingers, which is over 200, I think close to 250 units per centimeter squared. So it's like there's 5 times more receptors in our fingers than there are in our palm even, right? So that tells us something about what these parts of our body can do, some of the characteristics of these parts of our body.
And I think that's important to realize, because oftentimes with manual therapy, people will focus their view of the literature in a very narrow fashion towards, what is it done specifically for manual therapists, or in terms of palpation, in terms of therapy, what does the technique do itself? But if you kind of take a bird's eye view of, like we're talking about, of this concept of touch, there's a lot of research to indicate that systematic training of haptic touch, which is how we perceive touch in our body as the palpating practitioner. There's many lines of evidence demonstrating that we can improve upon our ability. And clearly the machinery is there, as you just pointed out, whereby the body is efficient, if anything. And when you see a utilization of resources such that you are going to create that much density of receptors in specific areas of the body, there's always an associated evolutionary reason as to why they're there. So even if you go from first principle science, if I'm understanding what you're saying, the mere fact that there's so much density, there's so much neurological attention paid to it, both from a peripheral standpoint as well as real estate in the somatosensory cortex, this tells us that the perception of touch is an extraordinarily important part of our sensory Umwelt as a species, our sensory environment and the things that we can perceive and take good information that will help us. Touch is a huge, huge portion of that, which is a trainable quality.
It is. It's a trainable skill. Like every other skill, the more you train it, the better you're going to get at it. So,
But even let's remove skill. Just trainable from a first principles receptor can get better at
Mhm.
tactile discrimination, pressure discriminations, you know, how things are represented in the cortex. There's
Right.
it's on experience and how experience in combination with touch perception, in combination with the brain's constant desire to pattern recognize and how we can
Mhm.
start to improve not only the physical perception of things, but how those perceptions are constructed in our brain and what it means. And we can make inferences and conclusions based on our
Mhm.
palpation over time and experience.
Right. Correct. Exactly. And so, every time, we're touching somebody, every time we're palpating, we're creating altering maps within our cortex.
Mhm.
So, there's plasticity there, and things, do change and they can improve um, as a trainable quality.
Okay, so now in terms of the identification, then you were talking about this concept that we utilize where we try to conceptually separate red stuff from white stuff, muscle from connective tissue. You alluded to the fact that this is an artificial or an arbitrary dissociation. But just for people listening, if I can put words in your mouth, we're saying that there's, the muscle proteins whose job it is to move past one another under the direct guidance of the nervous system. And then there's this previously thought was a passive milieu of connective tissue, which we now know is not as passive as we once thought, which transmits these forces created by muscles moving into the connective tissue scaffolding that they live in, and that contraction
Right.
muscle propagates forces along or energy or strain energy along connective tissue, which then spreads out through the entire body. So you have this mechanotransduction or this what's the word I'm looking for? This neurologically sensitive red tissue, which is functioning utilizing its pull response against this connective tissue density.
Right. And
Okay.
so what happens is that, and again, this might, fall under the assessment part, which we're going to talk about maybe a little bit later. But yes, you're providing then stressful conditions onto this tissue. We do that using length. And when you lengthen tissue, it gives us a story of what that tissue tells us, the behavior of that tissue. And
Mhm.
so we're going to use these stressful conditions in order to interpret what might be happening histologically, anatomically within that tissue. But
Okay,
before we
so
do that, we just have to
yeah,
find that tissue first, right?
I was just going to say, so let's talk first about identification in terms of anatomy. Clearly, anatomical knowledge um, translates somewhat to clinical intervention. I would say that the way that we learned anatomy historically possibly wasn't the best way for us to understand anatomy in a three-dimensional framework with a living system,
Mhm.
which is one of the reasons why we teach palpation as part of our as part of our connective tissue management system, simply because translating two-dimensional anatomy into three-dimensional live human beings isn't always easy, but it is doable. So, we talk about the utilization of reference structures and
Mhm.
reference structures, which maybe you can just talk a little bit about why we use reference structures, what those are, and how those allow us to translate anatomical knowledge into actual physical palpation skill.
So reference structures really are things that, they're anatomical structures that are pretty much common to everybody or most people.
Mhm.
So these are things that, really don't change in most of us. And so we use these as kind of fixed structures or fixed areas where we're going to use them in order to be able to find other structures in the surrounding area. So the way I always describe it when I do these seminars is it's like going to a city and you're using some of the big landmarks, and you're going to use those big landmarks in order to move around the city. So we're doing the same thing now where, whether it's the shoulder, the hip, or any other part of the body, we're using specific structures that are easy to find. They kind of stick out, right? And so we're using these structures in order to be able to move around and be able to palpate some of the surrounding tissues as well.
So
So
really,
that's one of the things that we use is reference structures.
okay, continue then.
The other thing that we look at is fiber direction. So you talked about anatomy, and so being able to understand anatomy to a certain extent and understand how tissue fibers kind of move, because they tend to move in a certain way. So the bicep is not going to move, left to right. It's always going to go up and down. So we have an idea of which way that fiber direction is. It might change slightly on everybody, but using a reference structure and getting onto that bicep, then we're going to be able to use fiber direction, knowing that it goes in north to south direction, that we're going to move in that direction or define the bicep. Okay.
Okay, so that's what. So we have reference structure. For example, once I can convince someone that they are on the distal bicep tendon, it doesn't take much to have that person kind of move into pronation, and you kind of fall into that depression, whereby if you hook on the medial side of that depression, you're hooking on the pronator teres. So from there, you can move. You can, utilizing the fact that these muscles are wrapped in this epimysial layer, this outer connective tissue. The fact is that the density of that outer tissue kind of makes tissues feel like they're in sausage casings. And sausage casings, because they're dense, they live next to other sausage casings, which allow something that we talk about in our courses, the identification of epimysial grooves, or the grooves between these bundles. And that allows us to identify, something as small as, we have rectus carpi, or flexor digitorum, flexor digiti minimi, flexor carpi ulnaris. Depending, if you know the anatomy, you know what structures lead to the expression of the directionality, as you alluded to. You can find very small things, extensor digiti minimi versus extensor carpi ulnaris, which is ECRM. All of these things are palpable from an anatomical standpoint based on their anatomy. We talked about reference structures being one of those things. One thing that the last thing probably we should talk about is the idea that layering is also an important concept. So when we're teaching palpation, what do we, maybe you can talk about layering and how that factors in.
Sure, because I mean, people, this is where we go back to, palpation, people downplaying palpation, because some people, or, maybe some research doesn't show us stuff at a deeper level, and people tend to use the psoas as an example here, and we'll get into this a little bit later. But people, because, there's discrepancies between palpation of the psoas, for example, they kind of discard palpation altogether. And I think that's a huge mistake. Having a systematic way of looking for things, so assessing and using palpation to do so, if it's done in a systematic manner, there's research that's provided that shows us that, yes, it can be very reliable. So for more superficial stuff, we have epimysial grooves, like you said, we have fiber direction, and these are going to be very important as well as reference structures. When we get deeper, this is where the problem happens. So as we get to the deeper structures, we need to be able to use some type of layering to get to these tissues. And this is where people make the biggest mistake, I think, when it comes to palpating, is that if they're going to try to find something a little bit deeper than the more superficial stuff, they're just going to smash tissue, kind of like power drive right through everything to get to the deeper stuff. And that's not a way to assess, because all you're going to do is you're going to hurt somebody, you're going to create pain, you're going to create tenderness, and that's not an outcome measure that you want necessarily, right? So what's going to happen is that you're going to get a false positive, because somebody's going to have pain just because you're pushing and smashing tissue, and not because really there's a problem there. So when it comes to layering, and we use what's called layering technique in our courses, what we want to do is really, what you're doing is that you're trying to decrease the resistance of the more superficial tissues in order to get to the deeper stuff. So what I'm trying to do is use less force to get to the deeper stuff so that I don't inflict any pain, so I don't create a compressing and a jamming of tissue instead of slowly getting to the deeper stuff and being able to then assess those deeper layers.
So this is important. I'm going to kind of pause and talk about one thing here because, again, we keep alluding to this idea of people who are, in our opinion, trying to find problems with the concept of palpation. But I think it goes without saying, but maybe we should say it, is that we don't think we're ever directly palpating anything per se. Like when I say I'm palpating the bicep, everyone should understand that I'm palpating the bicep indirectly through my contact, through the skin, through the fascia
Right.
superficialis, through the fat that lives in those layers, onto that fascia profunda, and then through the fascia profunda onto the epimysial layers, etc., going deeper. So everything's an
Yeah.
indirect palpation. So let's start with that. So when we talk about palpating deeper structure, multifidi, for example, um, tibialis posterior would be another example. Of course, you're unable to move your way through the superficial overlying gastroc and then shimmy your way through the soleus and then touch the tibialis posterior. No one's saying that. Straw manning these arguments happens a lot, so that's why we have to explain. Clearly, no one's saying that you are doing that, but there are ways to prepare the environment such that we have the best ability to indirectly get as close as we can to the tissues that we are attempting to palpate. And one of the ways that we do this is by layering. So let's hold psoas off for another conversation because that causes so much anger for whatever reason. We'll go back to the triceps surae group, where people tend to often mess up is, I'm treating the person's leg is perfectly straight and they're prone and they're effleurage or whatever they're doing, and they're treating gastroc. And then they do the exact same movement. They say, well, now I'm treating soleus. And their concept is that I'm kind of pushing harder to get there. Now, what we're saying is that if you utilize your anatomical knowledge, you understand where the vast majority of tissues originate and insert. Of course, we don't like the concepts of origins and insertions, but there is, to a large extent, fibers that insert and originate from in different areas. If we're familiar with these concepts, there's ways for us to layer our way down whereby we can get the tissue to be as pliable as possible by shortening the tissue. The example in the triceps surae group is if you want to get to the gastroc, by all means, go right through the skin with the legs straight. But if you want to go through that soleus, it would behoove you to bend that knee. Considering the gastroc covers two joints, the soleus covers one. By bending the knee, you are taking that gastroc and now it is in its most pliable state, whereby lower amounts of compression will lead to dissipation of water content, allowing that gastroc to be as thin as possible so that you can palpate the underlying structure of the soleus through the gastroc. If you want to go one layer deeper, then it's a matter of playing with the pronation of the ankle, because now we want to do the same thing with the soleus in order to get to that tibialis posterior. So there's ways to manipulate the anatomy in three-dimensional space in order to improve our capabilities of palpating that underlying tissue.
Mm-hmm.
Okay.
Yeah.
Okay. So now we
100%.
have anatomical knowledge. We have the fact that the muscles are sausaged, so to speak, into discernible bundles based on directionality. We have the epimysial grooves and our ability to distinguish muscle bellies. We have our ability to layer in order to get to deeper tissues. Do we want to jump into let's just get right into the conversation now about the psoas, because it highlights this idea of
Sure.
layering. So over over our time as therapists, we've gone through quite the roller coaster ride of it with regards to palpation, whereby at one point you learn all this palpation in school, and then you get out and then you hear people talking about how palpation is not been studied enough, even though clearly it has been. Those people are talking about very specific constructs within palpation literature that we'll get to, but it has been palpated. There's more than enough evidence to demonstrate its usefulness. And then, but during that time, there was kind of a lot of people who were downplaying the importance. And now, as we're going to get to, we have an uptick of importance whereby many, a growing body of professional opinion and literature is explaining that palpation is indeed some of the only outcome measures that are important as therapists to be utilizing, et cetera. But, there was a time where we were teaching palpation for years, and one of the things we taught was palpation of the psoas, and the amount of anger that this brought out in people was astonishing. It was incredible. Like
Right.
there was these camps of this impossible to palpate psoas, and a variety of different reasons, none of which actually made sense to me, but these people were very loud about it. I suppose we were discussing it off air a little bit. Can you give me a little conceptual framework with regards to how surgeons maybe understand this problem or lack thereof of palpating the psoas? We were referring to abscesses and such.
Yeah, that's an example. I gave you, off air was the fact that surgeons are able, they use palpation quite a bit. And actually, one of the things that now with laparoscopic surgeries and microinvasive surgeries, where they're not able to do like open surgeries and palpate, because palpation is a big component of even surgeries. I mean, surgeons when they're doing various work, they're looking for vessels, or they might palpate for a lymph node that's hidden, and so they're not able to do this using laparoscopy many times. So it's one of the things that science is working on, as far as like we talked about earlier about haptic touch and haptic perception, and creating some of these haptic sensations in machines and some of the robotic surgery that's happening. But surgeons also, have to look for, let's say, there's in the literature stuff like a psoas abscess, and for a psoas abscess, surgeons need to palpate for that. I mean, they're gonna confirm that using maybe an ultrasound or an MRI, but clinically, it's one of the things that they do is they might have to palpate for a psoas abscess. And so, I think if there's a systematic way of it, we're still at the point of looking for something. We're not talking about assessing, but we're talking about just identifying the psoas.
Yeah.
And so, like you said earlier with the tricep suri group, where you're layering through the gastroc and you're layering through the all the deeper stuff of the tricep suri group, going all the way down to the tibialis posterior and the flexor digitorum, and you're going through all these tissues. You're doing the same thing with the psoas. And so, as long as you're able to kind of navigate through that area, and we're not saying that you're getting rid of those intestines. It's not like I have a scalpel and I'm kind of getting those intestines and cutting them out of the way. But if you use a systematic and a logical way of doing things, for example, the intestine, they're not just kind of sitting there, they're able to move around, they have connections to our, the abdominal wall. And so if you use, for example, position matters. So if you have somebody in a sideline position, all that abdominal tissue just doesn't sit in one position. If I lay on my side, my intestines are going to move to, with gravity downwards, right? So that's going to.
I got to pause you right there because this is one of those straw man things that you hear a lot. You can't palpate the psoas because all this guts in there, and there's organs,
Arteries.
etc. Was that?
There's the arteries, veins. There's
Okay,
the
so let's just unpack that. Clearly, we know that, right? When they say organs in general, it makes me laugh because it's not. First off, it's not like organs just kind of float around in a soup of liquid where the liver is now passing over to here now. I realize that we don't have a fluid-filled sacs where organs live. There's very specific areas where organs live, most of which are stuffed underneath the ribs, whereby the palpation of those organs in and of itself takes a very specific anatomical knowledge and skill in order to palpate them. So for the most part, we're talking about the abdominal tissues, the intestines, etc. Now, so it's not floating in a soup. So that's one thing that people, they straw man you and they say that, there's organs everywhere. There's not organs everywhere. There's organs in very specific anatomical spots. Having said that, the other concept here is people will denounce your ability to move organs out of the way or to move intestinal matter out of the way. And to that, it's the other extreme. So in one sense, there's the idea that there's organs everywhere and you can't get past them, which doesn't make any sense. There's not a lot of organs right here next to my umbilicus, is you know what I mean? So that's one. But then the opposite concept is, there's all these organs and they can't move at all. And that's wrong as well.
Right.
Okay, so yes, there is fascial connections, there's of our organs. It's not like our liver can just all of a sudden end up in a different quadrant, right?
Right.
However, it is not the case that our organs are completely adhered to the abdominal wall, because if that was the case, as soon as you got into a motor vehicle accident, or if you got jarred quickly, you would end up severing and ripping most of those connections. So there is play, there is movement, especially of the lower gut content, whereby if you push into tissue, you can absolutely move tissue out of the way. If you
But don't forget, these tissues are made up of, various fibers. So, we're talking about mainly, elastin type of fibers, maybe less collagen in the viscera. So there's a little bit more elasticity here to play with, right? So that's
Sure.
something to also consider. So again, it's just thinking things in a logical way,
Yes.
and not taking the extremes, right?
Yeah. And I mean, yeah, are you sometimes compressing some of the abdominal contents into the psoas? Of course you are. You're of
Mhm.
course, of
Of
course.
course.
There's no, but if we speak about that, so stuff does move. That's our point. The other thing I want to remind people is the idea that, oh, you can't get in there, it's just so deep into the gut, and people just kind of point like this. But I want to push back on that, because where does the psoas lie? If you take a vertebral body, if you take uh, a vertebra, the things that we can palpate back here being the spinous process is, let's give it an inch in in in,
Mhm.
in length. Okay, so that puts us 1 inch in to this depth that we're trying to palpate in order to palpate the psoas. So that puts us in 1 inch. Then, of course, you have the spinal canal where the spinal cord comes down. That gives you another, let's give it a half an inch, maybe a little bit more. So, we're at 1.5 inches. Then in front of that, you have your lamina, and then you have the vertebral body, which pushes you even further. So by the time you're there, a vertebra can be anything. I'm assuming, I don't have an accurate measurement, but from all the anatomical cadaver dissections that I've done, it's about yay big. And that
Mhm.
psoas is going to sit, right beside the vertebral body in the lumbar spine,
Right.
which means that it's not all the way in. Like, people make it seem like you have to palpate through this much tissue in order to get to it. But really, you're palpating through that much tissue. And we just said that that tissue is extremely pliable tissue. It does in fact move. And we're not saying that you're ever moving through it. Oftentimes if you're doing it properly without any darting motions causing pain and muscle reactivity, you're slowly making your way deeper and deeper into that tissue. So it's not inconceivable. And I know I'm there, and you know you're there, and we know we're there because I can argue that I've, on almost every client, been able to feel the bony prominence of the vertebral body. If you're starting in, the lateral rectus abdominis epimysial groove and you work your way in and medially, it doesn't take very long until you abut into a very hard structure, which is the vertebral body. As a matter of fact, if you just take a second to abut into the vertebral body, oftentimes you can very clearly feel the direct palpation of the abdominal aortic artery. Uh,
Mhm.
if I would have said this 10 years ago, people would have thought I was crazy. We've been teaching this forever, but it's not even a hard thing to do. And then, not, further than that, if you're when you're at that specific area and you ask the person to just initiate a hip flexion maneuver, there's a
Right.
distinguishing layering between what you feel when they hip flex versus if you tell them to then relax and do an abdominal curl. You can very easily layer yourself off using the rectus abdominis. And then if you relax the rectus abdominis and just get them to lift the leg, you can feel a deeper seated contraction.
Correct.
Convince
And,
me I'm
that, that's
not on the psoas. Like, what am I missing here?
and that's it. Like, we're not saying, this is easy, but if you're using a methodology and a system that's, uses logic,
Mhm,
in that area, like you said, there's not a lot of things. There's guts, there's an artery. So if you're feeling for, a pulse, you got to get off of that. The only other tissue, if I create a contraction of my hip,
mhm,
like you said, layering through the abdominals,
mhm.
the only thing that's going to be able to contract there is going to be the psoas. There's nothing else there beside those vertebral bodies to contract. So that's, all we're saying is that being able to identify the psoas, if you do it in a systematic way, in most people, it shouldn't be difficult.
Okay, so and I know there's like floating around on Instagram land, there's this one um, post that I saw, and I can't attest to the validity of it because I don't know that it's been published yet. But there is a claim now with imaging that they did some study of ultrasound guided palpation, and they took pictures of
Yeah.
therapeutic hands inside palpating people, and from their conclusions, it very easily demonstrates what looks like almost a direct palpation of psoas. Again, I don't. Hopefully this is going to be studied. If it hasn't been done, I hope that researchers listening do it because this is a very easy, I'm assuming, easy study to do. So if it wasn't done and that was fraudulent, please do it. And if it was done, please publish these findings. Do you remember which one I'm talking about?
Yeah, I kind of passed by it as well.
Yeah.
It hasn't been published yet. It's some
Mhm.
university, I think, in like southern US,
Mhm.
and I saw that where it's an MRI image. I don't know if it's a functional MRI,
It's MR, not an
where
X. Yeah.
they're palpating on the one side the psoas. But again, like you said, if it is, hopefully, if this is something that has happened, hopefully it will be published, so we can kind of take a look at it and see how it relates to what we're kind of saying.
Mhm. And I also want to point out, of course, when if there is literature to demonstrate our inability to be able to palpate something, we've been perfectly willing to incorporate that into our teaching as well. And the one that comes to mind, the lateral pterygoid, for
Mhm.
example, in the
Right,
how many textbooks still indicate that palpation technique where you go up the upper molars and then pass your way up and through under that zygomatic arch? You're really palpating the descending tendon of the temporalis, and you're not anywhere close to the lateral pterygoid. Which, by the way, if people would just systematically explain it properly, they would start diagnosing a lot of descending temporalis tendinopathies instead of misdiagnosing
right,
lateral pterygoid spasms. Um,
right.
which again, so okay, and in regards to identification, then the the hard
So,
the hard. Oh, you have more. Go ahead.
well, one more thing that I wanted to add was something that we mentioned at our last FRS summit that we did in Prague.
Hmm.
Where I did that presentation on the ankle injury, and going back to palpation, stressing to some of our colleagues, if it's done in a systematic way, how important it is as part of the assessment. And the International Ankle Consortium, uh, has created guidelines. And one of the things that they've mentioned in the guidelines is in order to be able to assess for an ankle sprain and injury to some of the ligaments is using palpation.
Mhm.
And I know that we did the same thing in November when we did the summit in the US in the
Yeah.
FRS. And you mentioned also for groin strains, again, using palpation to as part of our assessment is very important
Mhm.
in the whole process of assessing those tissues in order to be able to differentially diagnose where the problem is.
And these are sports medicine consortiums that are coming together.
Correct.
And I can't remember the one in where the study was done for the groin. Maybe we can put it in the notes afterwards. But there's
Sure.
the consortium for the ankle, which you
For
just
the ankle.
do you have any information on that, or you're just going to put we can just put the reference?
Um, it was just a consortium that was done, and
Yeah.
this is where all the scholars and
Yeah.
clinicians and academics
Yeah.
related to ankle injuries meet. And
Mhm.
so in the guidelines that they set forth,
Mhm.
one of the things that they mentioned was that part of our assessment should be palpation of these
Mhm.
of the ligaments that might be injured. Now, um, in order to palpate, you need to be able to identify. And I mean, in order to assess, you need to be able to identify these structures, right? So
And
this kind of
unfortunately, we've had a lot of years of people telling students that palpation is unnecessary and unimportant. And this is where I feel that this is a big baby with the bathwater scenario, if that makes sense, where people do literature reviews and they're looking only for exactly what they're looking for
right,
instead of being able to extrapolate information from first principles. And I think what we've been arguing is if you extrapolate the information from first principles, there's more than enough reason to continue to search for or to continue to do palpation research because clearly touch is beneficial. Clearly, touch is important for diagnostic purposes, not only for therapists, but for surgeons over a wide variety of disciplines. There's clearly enough information about the density of our receptors and what they do and their ability to improve and our ability to expand or improve our sensory umwelt and our ability to improve haptic touch and how haptic touch and systematic training of haptic touch has demonstrated changes in the somatosensory cortex, which then infers that there's changes in receptor sensitivity, like in these Ruffini's corpuscles, these Meissner's corpuscles, the Pacinian corpuscles. There's more than enough information, and unfortunately, there was a significant amount of time there where people thought it a better idea um, to look at a very small amount of literature and make very broad-based conclusions from a very small amount of literature on palpation from a therapist standpoint. Am I encapsulating what
yeah, exactly. And they're just gonna, they throw pretty much everything out the window just because there's one study showing that, you can't palpate, for example, and go back to the psoas. So it's like you shouldn't,
But
shouldn't bash.
what are the studies, John? What are the studies that would create this naysaying in regards to palpation? Like,
You know what? I think what happens is that there's a couple things. One is, people don't use a systematic way of palpating.
Mhm,
They're not able to do it in a very systematic manner.
mhm,
So it's done very randomly. So it's like, I don't know where anything is. You look at what we've learned in books, and it's not reality. And if you're not able to kind of transition from two-dimensional to three-dimensional, which is what you have in front of you, then you're not going to be able to use palpation in a way that's going to be beneficial
mhm,
to
mhm.
you as an assessor, as a professional. So that's one thing. The other thing, it goes back to what we talked about in the beginning of this conversation, is outcome measures. So the other thing is that people, once they find some of these tissues, they're not sure what to do with them. They're not sure how to assess them. So they'll
Mhm.
use pain as an outcome measure. And so what
Exactly.
happens is they'll just smash these tissues that they're not sure what they're on. And somebody says, "Oh, that hurts." Say, "Okay, let me just treat that."
So I'd like to dive more into that because this is what I was hoping you would get into. Um, in and around the same time where people are speaking negatively about the effects of palpation or the usefulness thereof, it seemed that that coincided with our newfound information about pain and how pain is processed in the brain. And I feel, and as do you, that there was a lot of confusion historically with manual therapy students and with manual therapy pedagogy, in that people began to associate what we do with the direct assessment and treatment of pain itself, um,
Right.
which again, I mean, it goes without saying that pain is a far more complicated
Uh-huh.
chemical, neurophysiological construct whereby you're taking in information from the sensory system, nociception information, touch information, temperature, all of these, and it's being constructed in the brain um, into pain. And as we've said, we don't get to touch the pain because the pain is hidden in this inch thick layer of bone that insulates our thinking mechanism where the pain is actually generated. So can you talk a little bit more about that historically about,
Well,
yeah.
we now know, through the literature and science that, pain is a biopsychosocial um, concept. So there's
Mhm.
more to it than just the biology. There's a psychological component, there's a social component to it. So, kind of the BPS model, the biopsychosocial model now comes into play in a lot of stuff that we do when we talk about pain as well. So, being able to understand that, we also need to understand that pain then isn't what we call a tissue-based outcome measure, right? So
Mhm.
it's a clinically based outcome measure, but it's not a tissue-based outcome measure, which is why that correlation between palpation and where the boo-boo is or where the pain is doesn't exist. Because
Yes.
we know that a point in our body that's tender doesn't mean that it has a problem, right?
Mhm.
Or a problem, if there's a dysfunction, doesn't mean it's going to be painful.
Mhm.
So we can't use pain as that outcome measure.
Mhm.
And so when you take that away from somebody, then you take away palpation from them because there's no point in palpating for something if you're not, all you're looking for is for pain. So if you're looking for a painful area of the body, which doesn't really interpret into a problem necessarily,
Mhm.
and you take away that away from them, that outcome measure, then what's the point for them to use palpation? But when you're using tissue-based outcome measures, remember I said earlier that we need to provide stressful conditions onto tissue, onto connective tissue, onto muscular tissue, and we do this one of the ways that we do this, at least, is through elongation. So when you lengthen tissue, uh, it tells us something about that tissue, whether it's muscular tissue, which is nervous system controlled, or whether it's connective tissue, which is then falls under the length tension properties and components in the length tension curve.
Okay, so this is where I want to go into now, but I just want to reverse a second just to make sure that we understand that we're not saying that identification of painful structure can't be part of the palpation process in terms of making a diagnosis. Um,
No,
we're
we're
not
not saying
saying
that.
that. Okay, go
Because
ahead.
in the acute phase, this is where these guidelines that I just mentioned on the International Ankle Consortium and some of the stuff that's happening on groin injuries. We're
Mhm.
talking about acute stage problems here. So Achilles tendinopathy.
Mhm.
There is a study out there that shows that for Achilles tendinopathy, there was reliability in palpation of
Mhm.
that tissue because that tissue was in an acute stage and there was inflammation and it was painful. So if I have
Mhm.
a bicipital tendonitis and I
Mhm.
palpate on that bicep tendon, it's going to be tender.
Mhm.
So what I was talking to about before was more chronic pain. So we're talking about chronic pain being more part of that biopsychosocial model.
But the problem again is that when you throw the baby out with the bathwater, as we said before, because you're deeming palpation as ineffective, and then you have students who are being brought up in a culture where the idea is that palpation is ineffective, you have less people practicing the art and skill of palpation, um,
Mhm.
which means they're probably making less use of their two-dimensional anatomical knowledge, which means that they're probably getting worse at identification of anatomical structure, which even forget about interpretation, which we're going to get to, the lack of palpating, the lack of practice over time is going to make it so that, when a consortium of groin injuries comes out saying, oh no, you need to be able to differentiate the tendon of the adductor longus from the belly of the adductor brevis from the posterior face of the adductor magnus, well, it's too late then because you've lost the palpation. And again, part of this palpation is the conscious and subconscious drive for our nervous system to identify patterns. And the fact that you're not practicing and you're not associating areas of tenderness, or areas of increased resistance or areas of altered temperature or areas of altered texture, the fact that you're not pattern seeking for these things over time means that you are behind now. So now you got to go backwards, and now you got to go backwards into the re-understanding of anatomy, the re-understanding of what anatomy looks like in a three-dimensional model, layering technique, reference structures. So, I think we've
Right.
discussed that the identification process is important, it's trainable, and not a lot of people are doing it.
And it's not going to get better just by thinking about it, right?
Yes.
Which is why older practitioners, older professionals, you
Mhm.
look at some of the research that shows that, they took an experienced
Yeah.
professional who's been around for, 25 years in practice, and
Mhm.
they were able to identify
Mhm.
the structure.
Mhm.
Just because they're in practice longer doesn't mean they're good at palpating, right?
Yeah, we often say that. I mean, experience really doesn't mean you were paying attention.
On
And
its own doesn't mean much, right?
doesn't mean much. What we're talking about is mindful experience, right?
Right.
You said that about
Right.
that because I find the same thing in meditative practice where people assume that because they understand the benefits of meditation, that they somehow just reap the rewards of meditating without meditating because they think they understand it. Does that make sense? Or
Right.
another analogy is clients where you say, "Do you take vitamins?" You go, "Oh yeah, I take vitamin." What do you take? Vitamin D and a multi. When was the last time you took it? Well, I've been out for the last 3, 4 months, so I haven't been taking it. So you don't take supplements. Well, I guess
Right.
not. Well, it just so happens that supplements only work if you're actually imbibing the supplement itself. So it's the same thing with palpation practice. And so what
Right.
we're saying is, yeah, if your mindful experience would
Right.
improve your ability, and now we've discussed how improving the ability is starting to be pursed out in the literature as very, very important. So
Right.
let's go back to let's go to the second portion of it because I want to get into this as well, which is the interpretation portion.
Uh-huh.
Um, maybe first start off by giving me the over the bird's eye view of the literature regarding the interpretation. When we feel things, um, do people then know how to respond to what they feel? What does the research demonstrate in terms of our ability to interpret the things we feel? Because that's a completely different thing. To argue
Right.
the ability to localize, palpate, the psoas, the obturator externus, these other things, that's just a matter of me being able to get your hands on tissue and then sorting you through reference structures and layering
Right.
and how to get there. I've never had a client, I've never had a student come to me where I put their fingers on the psoas and they go, that's not it. I've had many of people come to our seminars who want to prove us wrong, who come in thinking you can't do it and then leave thinking, oh my God, I was being, you know, maybe overtly, unnecessarily aggressive towards the concept.
Right.
Forget about that.
Right.
Let's talk about interpretation. Where are we with regards to that?
Okay. So with interpretation, there's a couple things. Again, this goes back to outcome measures. It
Hmm.
goes back to the fact that what are we trying to interpret, right? Is it pain that we're interpreting? Is it a tissue-based outcome measure that we're interpreting? So we know that statically, we're not able to say much about that tissue. So, for example, we talked about adhesions before. And so statically, if I'm, identify tissue, so I identify the biceps,
Hmm.
and if I statically palpate the biceps, I'm not going to be able to say much about that tissue
Hmm.
because, for example, if there's adhesions in that tissue, we're not able to palpate for those things. Knots, we're not sure what knots are. Ropey parts of that tissue. All these things that people use, professionals use as findings. Statically, we're not able to say much about what that really is.
Okay, so going back to first principles here, never has a neurology textbook said that a Ruffini's corpuscle's job is to feel pain, or
Mhm.
that a Pacinian corpuscle's job um, is to feel adhesions. I think we have to drill right down into the neurology of this and allow people to understand that the vast majority of sensations that we're receiving from our fingers are mechanical in nature. I often say this in people just to bring people into this thought process. When you feel that something is wet, for example, people and therapists do this. I think they might forget that we have no receptors that feel for wetness. Like wetness is not a thing that we experience through our touch. So people, how does that make any sense? Well, if you take something out of the dryer and you can't tell whether it's wet or it's just warm because the temperature has changed, that you've done this before, there's a reason for that. Like when you feel water going down your arm, you're not feeling wetness. You're feeling second by second changes in temperature over a displacement, which you interpret as being wetness. So again, when you drill down to what we're actually feeling for, what these things feel for are light touch, um,
Pressure,
pressure,
pressure, hardness, texture,
deep touch,
temperature.
temperature, texture. Um, very specifically, they feel for these things. I mean, now with regards to palpation, we would hone in on Mesner's corpuscles, Pacinian corpuscles, Ruffini endings, because those are the ones that are really giving us information about skin stretch, about underlying tension, about pressure that we feel against our palpating contact. Correct?
Right.
Okay. So I don't know if I interrupted you there, but how does this play in now? You were talking about outcome measures. So if we're implying that the things that our receptors pick up are mechanotransduced signal, then is there a way to interpret what we feel or interpret how it's another thing that people, when you're feeling something, you're not shooting a special energy out of your fingers into the thing you're touching. What's happening is there's displacements occurring in your own body, and we have to learn to interpret those displacements neurologically as being associated with a particular finding.
Right.
Okay.
And actually what's happening in our fingers, and this the research shows this, is that there's changes that are happening as we're touching something. So there's changes in muscle tone in our fingers. There's changes in our joints
Mhm.
that are occurring. So there's a relaxation of the joint or a hardening of the joint, depending on where we are and how much force we put with our hands.
Mhm.
So you're right. Like what we're doing is that we're kind of like adjusting this tool to what we're trying to feel for.
I mean, at
And
a microscopic level, we're from a cellular level, from a anatomic level, or sorry, an atom level, we're really not ever touching anything. Like the fact that I'm
right,
hitting something solid that's my desk is because the charges of the desk and the charges of the atoms in my fingers repel each other. So it feels like we're actually touching, but we're actually not even touching. In other
right,
words, my ability to palpate something in you for a therapeutic reason is really not feeling what's in you so much as it's feeling what in you affects me and my receptors and what I feel for. And what
right.
our palpatory receptors feel for the most part, is pressure or tension or
Mhm.
resistance, so to speak.
Exactly. And these are some of the things that we use when we're assessing tissue. And that's why I said earlier,
Yep.
we're using lengthening to do that.
Perfect. So again,
Right.
I hate to keep jumping in, but what you're saying here is
And
that that's why you said static palpation gives us very little, because static palpation only allows us to feel the outer construction of that tissue, which is now we're talking about there's fascia upon fat cells, upon superficial fascia, upon skin, upon, there's a lot of upons there for us to actually touch or
right,
feel anything. But when you induce movement, as you're saying, length, you keep alluding to the fact that length allows us to extract useful information. So let you
right.
explain
So
that point. Go ahead.
That's how I would separate the two. So, statically, we can say that using static palpation, you're able to identify that tissue, which we've been
Mhm.
talking about all along. So we're
Okay.
going to use static palpation to find this tissue. So we'll look for those epimesial grooves, look for fiber direction, find where that tissue is. And then in order to be able to say something about that tissue, we need to create some forces in that tissue in order to feel something, to get some type of reaction from that tissue. And to do that, if you shorten that tissue, you're not going to get much
Hmm.
from that tissue. But if I lengthen a tissue, think of an
Hmm.
elastic band. So if I stretch that elastic band, what's going to happen is that there's going to be an increase in tension within that elastic band. So what we're doing is that, we're creating length in that tissue in order to be able to see what the lengthening properties of that tissue are. And if we understand the lengthening properties of that tissue, we're going to be able to understand the behavioral properties of that tissue and the individual that we have in front of us. For example, a hamstring. So you get somebody doing a straight leg raise, and get that leg to come up to 50 degrees or 40 degrees, and that's where you start to feel a ramping up of that tension, or maybe even an abrupt stop as you're tensioning that leg. So that's where I'm going to take that information now and try to incorporate it and translate it into an outcome measure.
Okay. Okay. So I think it's important at this point to start to differentiate what we're feeling for specifically, because you kept talking about lengthening. And I want to interject here and say that the lengthening that we're referring to is passive lengthening.
Right.
And the reason why it's not active is because when you start to tell people to lengthen, people have this weird idea that when I do this, somehow that my tricep contracts and my bicep relaxes. But in reality, when I do that, there's a lot of contraction in both my bicep and tricep. The way that people understand muscles is unfortunate because they look at them as an all or none concept, where if one's on, the other one's off, and those relationships don't exist. Like your brain, it probably understands that there's an area here that has a generally bigger thickening that we identify as the bicep. But from a motor unit standpoint, it doesn't understand things as the bicep so much as it understands things as the particular motor units that are functioning in that bicep at a particular time. It's way more complicated than bicep, tricep, on, off. That's not how it functions, okay? So when I'm moving into length, the fact that I'm doing it means that I'm going to already send neurological stimulus to the thing I'm lengthening. So of course I'm going to feel increased pressure, increased tension, because now I'm just feeling what the nervous system does. Now, this is not unimportant. If you have a muscle that is neurologically irritated, meaning that there's something wrong with the muscle such that the nervous system is sending too much depolarization to that tissue, spasm, tightness, muscle tightness, in that scenario, I'm palpating the tissue. Maybe because the muscle's tight, I push into the tissue, the Golgi tendon organs fire, it provides a resistance. I can feel, but that's what I'm feeling there is neurological tightness. The entire group is tight. But what we're referring to is when you go passive and you feel the behavior of the connective tissue itself, which is where the injuries accumulate, where injuries occur in our absorption properties of connective tissue. When we move connective tissue to length, what we're saying is that there is discernible information which is of benefit to us, and how things achieve length is important for us to understand. Is that what you're saying?
Right. And again, this kind of ties in with what we talked about in the beginning of this podcast with fibrosis.
Okay.
And so what happens in connective tissue is that we said, the fact that as it gets injured, you get a deposition of, various types of collagen fibers in that tissue. So what's going to happen to that tissue is that if I lengthen normally a tissue, I'm expecting a certain rate of lengthening, right? So I'm expecting that stress strain curve to have a very smooth, gradual increase in tension as I increase length. Now, if there's
before we move on, I'm gonna simplify this, and then you can take off with the more complicated terms. So what you're saying is that we know that connective tissues behave in a particular way under normal conditions, where you map a stress strain curve. Now, what's a stress strain curve? A stress strain curve is looking at, if you take a composite of tissue and pull it at length, the amount of length relative to the amount of strain energy that is built in the tissue when that length is applied. So you have the amount of stress versus the amount of strain. And what you're saying is that, I'm assuming I know this, but I'm going to pull this out of you. There is research to lead us to believe that we should expect that tissue undergoes a stress strain relationship, which is discernible in normal conditions, which is aberrant in abnormal conditions. So take off from there. So go ahead.
Correct.
Okay.
So what happens if you take a look at that tissue that's injured, what we're going to see is that we're going to see a change in that stress strain curve that you just mentioned.
So
So
before there's an injury, in normal tissue, that we have literature in all the connective tissues where if you excise the connective tissue, put it under length with ligaments, with tendons, we have this with, there is a one-to-one relationship.
correct. If I take a tissue, whether it's myofascial tissue, so
Yep.
if I take my whole bicep and I put it in a lab and I lengthen that tissue, or if I take part of that bicep, so I can take a component of that bicep, or even if I take just a fiber, like a myofascial fiber within that bicep muscle.
Mhm.
In all three situations, I'm going to see the same thing. If I pull that tissue in a specific direction, I'm going to see a gradual increase in tension as I lengthen that tissue. So that
Mhm.
myofascial tissue displays a behavior of a one-to-one relationship of stress strain curve or a length tension curve. It's pretty much the same thing. So as I lengthen that tissue, I'm expecting to see a gradual increase in tension within that tissue.
Which is at a one-to-one relationship.
Correct.
Okay, so that means, again, I think that it behooves us to, maybe I can put in the graphic later.
Sure.
But it behooves us to explain
So this is A.V. Hill's,
this graph here, this is a stress strain. So as length is broadened, so as we're moving in length, there is going to be a certain amount of strain because of that length. And that strain length relationship is one-to-one, meaning that this graph moves at a 45-degree angle. So we should be assuming, if we palpate a tissue from shortened position passively into length, that there is what we call an escalator of tension, whereby there's a gradual onset of tension, where if I move 1 inch that way, I'm going to get a certain amount of tension. And if I move another inch, I'm going to get a rise of that tension in the exact same linear relationship. That's what we're saying.
Correct.
Okay. So that means that if I take students, which we have now for the better part of the last 20 years, and we get them to palpate tissue from a shortened to lengthened position, which we do, when people are normal, they would be able to identify this gradual onset of tension. And then eventually you get to the end of the tension, and then there's what we call a yield point, where any further that tissue would break. Obviously, we don't get to the yield point. We get to the part where you have maximal amount of tension, which is denoted by end range. So if I bring you from here passively all the way to here, I should be able to identify these one-to-one relationships. And
Right.
if you practice doing so over time, let's say that you attend one of our courses and we give you a systematic way to identify and now interpret and practice what you're feeling, over a career of mindful practice, you can begin to identify the pattern that is normal tissue lengthening under passive load.
Right. So as that tissue lengthens
Okay.
from beginning to end, it's going to gradually increase. The stress in that tissue is going to increase gradually. So the stress, resistance, same thing. So as I put more strain onto that tissue, the stress on that tissue is going to be a lot more, right? So the resistance coming back to your hand from that tissue is going to be a lot more.
Again, so again, what we're saying is that the research has been done on excised tissue, so in you or in my client, conceivably. So what we're saying is, because we know the relationship in the tissue, right? And we know that that strain goes up at a certain rate, that our interpretation of those mechanical signals would be such that we would be able to feel the resistance to lengthening under our finger using the same parameter, whereby we would expect a gradual escalator of increasing tension as we achieve length in our finger, in our somatosensory cortex, in normal tissues.
Right.
Okay.
Right.
Okay, so
So
now,
now, right. So now what happens is that, let's say the tissue gets injured. And so we're going to get, deposition of various collagen fibers in that tissue in various directions. So what's going to happen at a microscopic level is that we're going to have various directions of fibers within a specific area, not within that whole tissue, but in a specific area of injury, we're going to get various directions in fiber direction.
okay,
So,
so just again, I gotta jump in, make sure everyone understands. We've said this, we talked about it in the last podcast. We're not saying that connective tissue in its entirety runs directionally. What we're saying is that depending on the level of connective tissue, there is more or less organization whereby more tissue runs through a particular directional pattern. We're not saying that there's not cross-linking, but we're saying on a whole, the composite of connective tissue is going to have a directionality akin to the way it is utilized, um, during motion.
right,
And that some of
right.
the tissues are going to have more organization. I believe last time we talked about the paramecium having a
Right,
lot of organizational structure
right.
versus the epimecium, which will have a lot more different directionality, but still, there's still a general directionality of tissue.
General direction. Right, because the perimecium is what then kind of blends in with the tendon
Mm-hmm.
and the peritoneum. So what happens is that the tendon has a lot more direction, so does the perimecium.
Okay.
Right. So now what happens is that there's an injury. So
Yep.
now, if we take a look at the same curve where there's a one-to-one gradual increase in resistance or
Mm-hmm.
tension, what's going to happen is that once I get to that area of injury, I'm going to get an increase in resistance within that area. So while I'm getting a gradual ramping up of tension, there's going to be a point where that tension is going to just shoot right up
Mm-hmm.
because I'm going to feel there's going to be a difference in tissue quality in that area.
So as opposed to, and again, I'm going to use the graphics to explain this maybe when we publish this, but sorry, this is a one. So we have in normal tissue, we have this one-to-one relationship between stress and strain. Yeah. But now what we're saying is in the composite of, let's call it the bicep, if there's tissue disorganization, okay, meaning that there's more tissue or less of the tissue has a directionality because there's more haphazard reorganization of connective tissue. Yeah, let's say that the angle of this stress strain curve will change. So now we have a change in the angle such that
Right.
maybe for 1 unit of length, we now have 3 units of stress or resistance
Right. So you can see that curve is shifting to the left.
to the left, which also brings the yield point to the left, which means that, and this is another thing that I often talk about. People often say because we do end range training that we say that most injuries occur in the end range of motion,
Right.
but that's not what we're saying at all. As a matter of fact, most injuries occur within the normal range. Why?
Right.
Because when you have aberrant connective tissue deposition, the yield point starts to also move such that now with less length, you are hitting amounts of stress that will otherwise exceed the load-bearing capacity of that tissue within length.
Correct.
Okay.
Correct. Yeah, exactly.
Okay. So now in our courses now, so what we're saying is instead of feeling that escalator, we start to feel things that look more like elevators, where you're palpating a certain area of tissue and you're expecting normal, but then somewhere under your palpating hand, as you increase length, whereas most of the composite of tissue is undergoing normal stress-strain relationship, there might be areas within the muscle, because we just said the muscle's not one thing, it's thousands of things. So there might be an area in the muscle whereby the fibrotic development is changing the relationship between how the tissue accepts length and thus how we perceive the tissue lengthening in our hands.
Right. Right.
So what you're saying, Doc, is that we're not busy looking for scar tissue And we're not
Right.
busy looking to break scar tissue once we find it. We are simply taking the mechanisms available to us, which is our ability to perceive tension and resistance, and we are
Right.
applying that ability to the first principles knowledge as to how tissue responds behaviorally to the application of passive length.
Exactly. Exactly. So we're pretty much just using, what we're saying is that, if we're going to use our hands and, we're professionals, we're manual therapists, whether it's a physiotherapist or a chiropractor, we're using our hands to assess and to find things. And what we're saying is that at least do it in a logical, systematic manner that's going to help in your assessment process.
Okay. Let's tie this back now to, okay, so I want to go back a little bit now to our ability to perceive such things. And I'm going to speak again about the human's capacity to pattern recognize. And
Okay.
that I've never had a scenario where we teach palpation at one of our courses and then someone automatically they feel things incredibly better than they did previously. Going back to the meditation thing, just because I explained to you the benefits of meditation, it doesn't mean that you get to claim the actual benefits of meditation just because you thought about it. It actually takes practice. So
Mhm.
we've never said that we can improve your ability to perceive these changes, but now that we understand what we're supposed to be perceiving and why, and we understand the first principles of how, with regards to how our receptors function, what we're saying is when you combine this information and you mindfully practice as a therapist, as we do, whereby on a daily basis, we're not only palpating and interpreting what we're feeling that are normal things, but we're also finding problems in tissue and associating pain with findings, or we're associating conditions that we find with palpatory changes. Our ability to pattern locate and to start to interpret what we're feeling based on our pattern recognition is what then takes a relatively okay therapist and makes them a sensational therapist. Similarly, when you go, it's very hard for people to deny that when you go to one therapist versus another, their touch feels different. And the experienced people that we've talked to and dealt with many of the greatest researchers on the planet on this regard. We've taught palpation at university settings, at college settings for 20 years now. You can tell when someone has been paying attention. You can tell when someone has mindfully trained their haptic touch. Just like you can tell when someone mindfully trains to be a musician. Like it's very easy to look at fine motor skills in a musician, which, by the way, literature has demonstrated increased finger pad sensitivity in musicians and in surgeons. For whatever reason, we don't want to extrapolate that to manual therapists, but maybe
How
it's
about people that read Braille,
how about
right?
people that
Same thing.
read Braille? There's another good example. I mean, talk
Yeah.
about our ability to pattern recognize. And if you want to, talking about the baby in the bathwater, if you want to take all of this information and say, you know what, based on the few studies that have actually really looked at therapeutic palpation, there's some on motion palpation of vertebral segments and how
People say,
there's
yeah,
not a lot of good interrelator reliability between our ability to feel, but there's good reasons for that as well. I mean, motion segments move in millimeters, not in inches, uh,
right.
whereas tissues to large extents slide past or wiggle past one another to greater lengths. So even conceivably, the idea that we can't palpate, I mean, I can say the same thing about our sutures. I'm sure that there's, there's some give in a baby's suture, but our ability to feel that, like, it's small, just like our ability to feel, T5 moving on T3 in rotation. I don't think that that's
Or the SI joint, for
or the
example,
SI joint that has what, 3 millimeters of motion at best, at
three,
best
four
case.
millimeters.
So that's a poor way to throw the baby out with the bathwater, to look at that kind of research and go, oh, you see, no need to palpate because we can't do that. But I think, like every other problem, there's nuances to this,
Of
and
course.
it's very easy to strawman arguments, especially maybe by people who haven't paid attention to palpation, as you said. If we've put in a good 20, 25 years of mindfully doing this. So it's like we might have a skill. Maybe we're playing guitar and other people are just learning their chords. And maybe there's a difference there, which is difficult to perceive. But based on the research that we've laid out, I think it should at least interest you that perhaps there's a there. There's something there, considering all of our knowledge about touch and how it benefits pain and anxiety. And forget, we talked about how it doesn't. We talked about pain a little bit and how we don't touch pain. But there's a lot of research about post-surgical clients that have cancer, for example, and how touch decreases pain levels significantly, decreases anxiety, decreases time to return to function. I mean, there's just
Decreases cortisol. Increases parasympathetic, the
there's
parasympathetic system.
immune benefit, immuno benefits to touch. I mean, there's so much there. There's so much there. And then if you tag that along with our ability to improve our sensory processing, and you tag that along with all of the machinery that we've discussed that we have in our hands, and the sensitivity of that machinery. Like we're talking about we're talking about sensitivity to the extent that people can learn braille and people can pattern recognize. It just seems to me like people should be erring on the side of, this is an important skill that I should have as a manual therapist. And I'm going to argue now as a trainer. And I don't want to bogart the conversation. I'll pass it on to you. But another thing that we've realized is, at one point we were only teaching palpation to our manual therapy students. And then we opened it up to anyone taking any of our courses in mobility training and strength training, the ISM, the FRC. And what we found is that the benefits of of palpation training to trainers. I mean, it's the benefit is insofar as you can be as specific as you want or as general as what you want with your training. And general inputs lead to generalized results, and specific inputs lead to specific results. Now, we don't teach our trainers to become therapists, but the ability to just identify anatomy, understand the three-dimensional framework of the anatomy. Maybe they're not going to be palpating um, for tissue damage per se, but their ability to localize tissue, their understanding of anatomy and how it relates to other layers of anatomy and how the movement between layers occurs, and being able to feel that movement and to feel how things achieve length. Trainers stretch people all the time, but never along that time did we ever teach them to put their hands on what they're stretching as they're stretching, just to see if they can, subjectively get information that they can then utilize, um, not necessarily with regards to therapeutic intervention, but with regards to exercise intervention. It's immensely positive for trainers to also experience this kind of learning.
Yeah, it's huge. I mean, during the seminars, I've had from orthopedic surgeons come to an FR course,
Mhm.
just to get better at palpation, so that they may be able to for whether it's injecting somebody with something, and being able to be a little bit more specific in a knee injection or a shoulder injection.
Mhm.
To, like you said, now we're opening up to trainers, and we're not going to make trainers, like you just correctly said, therapists, but if you want to be, let's say, a little more specific with your training, let's say we did this with the FR summit that we just did in Prague. And, want to do some exercise training for the ankle. You want to be a little more specific to some of the ligaments in and around the ankle. A trainer being able to understand the anatomy and being able to identify where that anatomy is, I think you'd be a lot more specific with the load that comes with exercise onto those tissues. And
Mhm.
that, of course, is going to result in, better results because you're a lot more specific into loading that tissue and just generalize exercises.
And I think that also goes, I mean, it probably is worth mentioning that, yeah, if you apply general standard procedure exercises that many people do where they use named exercises, they might not associate the need for it being that specific. But what we're referring to is if you're a trainer and you have a client who has chronic lateral ankle inversion sprains in their ATFL, you can't just, there is no mouth noise exercise that will tell you how to stress the ATFL under progressive load in order to change the ability for that tissue to absorb load. Like there's no hack squat, like leg press, like nothing does that, right? And maybe that's why people find it unimportant. But we know that if you're a trainer who has someone who has chronic ankle sprains, inversion sprains, that you can, number one, assume that the injuries have left anatomical consequences. Number two, you can now palpate those anatomical consequences. And number three, your understanding of now the anatomy um, will improve your ability to, sorry, the understanding of anatomy will improve your ability to construct inputs that will stress that tissue very specifically.
Of
And again,
course.
we talk about training from a very specific standpoint, whereby how you influence muscle growth is not the same way that you influence absorption capability in the white connective tissue. Um, so again, if you
And since you mentioned the ankle, and
yeah.
so in the ankle, the research shows that uh, about 6 to 8 weeks post injury, that person is 60% better. That
Mm,
tissue is at 60% capacity. And what
mm,
happens many times, the person goes back to their sport and they get
mhm.
re-injured. And there's a couple of reasons for this. One is because the load bearing capacity of that tissue isn't where it should be. And the other thing is because that training program wasn't specific enough to that tissue to bring that tissue capacity up to where it should be when they return back to sport.
It's amazing how people are very quick to negatively interpret palpation literature, but they don't take the same vigor to their analysis of return to play literature, um, which is wildly unspecific. I mean, really, return to play is a way of saying, I need you to compensate for your tissue's inability to absorb load using other tissues. Can you do that dynamically with this dynamic challenge? Yes, then you're okay to go play. It's almost like you're testing the ability to compensate for this injuries that are, as you're saying, still present, but may not come out in a run over there, touch the floor, and run over here, touch the floor type return to play drill.
Right.
So those
Right.
return to play drills are not specific to tissue function, just like a lot of palpation literature hasn't been, but it doesn't mean that you can't extrapolate information from first principles literature, which is, again, what I think you've laid out quite brilliantly in this podcast is that there's a lot more to consider. Um, from what we know, the idea or the gut reaction to get rid of palpation and to get rid of the the utilization of therapeutic touch is a reflex which is I don't believe is scientifically founded at all. If anything, it's based on a narrow misinterpretation of a very small amount of literature, um, which can be corrected by stepping back and taking a more bird's eye view of what we understand about the system's ability to interpret mechanical signal.
Yeah, and a lot of we talked about this again, how a lot of the consortiums, a lot of the guidelines now kind of get us back to using palpation, of course, as an adjunct to everything else, right? Using it as a tool with other assessment tools to be able to get a better idea of what's happening with that, Homo sapien in front of you.
Hmm. Well, John, I know that we can do this for another 2 hours. Is there anything
Yeah.
that you think that we should have covered that didn't? It doesn't mean we can't do this again, but are there any closing kind of ideas or words of advice uh,
I think the
from a
big thing is,
biochemist slash chiropractor slash physiotherapist slash
yeah,
international teacher of palpation, which you have been for the last 20 some odd years?
I think the big thing is kind of, just, making sure that, all our colleagues watching us out there, just making sure that they kind of reconsider a little bit palpation and, some of the stuff that we talked about, some of the concepts that we talked about, and, making it part of their assessment tools. And I think just being a little bit more specific with their assessment is going to make their treatment and their training a lot more specific as well. So,
Mhm.
just kind of, listening through what we've talked about and just kind of maybe hopefully putting some of the stuff into their own practice.
Mhm.
Hopefully will help.
Timelines is one thing I just popped into my head is one thing I think that we should leave people with is the idea of timeline and the idea that because we think of therapy as the thing that is done in the moment the therapy is being done, that leads us to a confusion. What we're saying is repeated, specific inputs repeated over time will take these findings, these elevators of palpation where we have, aberrant increases in tissue tension with minimal length. We can change those qualities. We can reestablish normal by improving on the connective tissue architecture, and then not just by doing it with passive input, but by progressively loading tissue specifically in time, so that we start to renormalize. Renormalize is a bad word. That we start to normalize the connective tissue behaviors, which we have felt, which therapists for many years, uh, many years beyond the number of years we've spent in the scientific method. For many years, there's people who have felt these changes that occur in time. But I think the timeline's important, that you're not expecting changes immediately. And the next time the client comes to see you 2 days later, you shouldn't expect changes. That's why I noticed that with therapists. Hey, how's that feel? Does it feel better? They push into the same areas. If does that feel better? Oh yeah, it feels a little bit better. Oh good, it's because it's better. No, like I know that if I feel finding now, if I feel aberrant tissue behavior now, I'm not going to feel a change in that aberrant tissue behavior for weeks. Just like
Right.
a training, program, you have a 6 to 8 week, flux of I'm going to do connective tissue training or I'm going to do speed or whatever it is. You need to start thinking in terms of these cycles of time, 6 to 8 weeks, and then see how we're doing. How is the loading? Did you progress the loading? There's nuances, I think, and I think that we've discussed many of those nuances, and we could further discuss those nuances. But like you said, it's important for young therapists to hear these words and to realize that they're not wasting their time by honing their craft and trying to master that skill of palpation. It will pay dividends for your patients in the long run, and we know that from not only our career but the careers that we've influenced around the world by teaching connected soft tissue palpation and therapy.
Right.
So
Exactly.
we're good to leave it
That's
at
a good
that.
way to. That's a good way to end it. Yeah.
Okay, my friend, we will talk soon. Hopefully we do this again in a
Yes.
relatively short period of time. Thank you very much for your expertise and knowledge.
Thank you.
Okay, we'll see ya.